So, good evening, everyone. Welcome to today's webinar on Neurooncological Surgery Advanced. We're happy to see many participants joining us, united by the shared commitment to advancing care for patients with brain tumors. As we all know, the field of neurooncology has evolved rapidly over the past decade, driven by groundbreaking innovations in surgical technique. So our today's expert speakers will guide us through the key topics of neurooncology surgery advanced. We encourage your active participation throughout the session, so please feel free to post your questions and insights in the Q&A, and we will discuss them following the presentations with the aid of our panelists Jiří Bartek and the Neurooncology Section Chair Matthias Simon. I thank you all once again for joining us, and let's begin an insightful and inspiring session on the forefront of neurooncological surgery with our first speaker coming from Sweden. And I'd like to invite Margaret to talk about motor eloquent gliomas.
Thank you, Christian, for the invitation and to the whole neurooncology section of the EANS. It's an honor to tell you about how we treat motor eloquent gliomas. I have nothing to declare, and as
Margaret,
you are
we
very well
cannot
aware
see
of
your presentation.
You cannot see the...
Could you please try and share again, please?
We will start again with the sharing here, and
now we can see the PowerPoint mode.
and now hopefully
Yes,
the
it works.
slideshow mode. Well, thank you again to the neurooncology section, and I will tell you about how we treat motor eloquent gliomas here at the Karolinska University Hospital in Stockholm. I have nothing to declare, as I mentioned, and in neurooncology, you are all well aware that the golden rule or the standard is maximal safe resection, and we all try to aim for the oncofunctional balance. And when it comes to motor gliomas in or near the motor resection, well, the safe part of the golden rule becomes very important. And I will like to, in a short time, go a little bit through the definition and epidemiology of eloquent gliomas, how we do the preoperative workup, but focus on the surgical techniques, how we can do the procedure as safe as possible, and a little bit on the surgical outcome. So the definition of eloquence is for motor gliomas, mainly the primary motor area, as you can see here in a paper from Chang and the San Francisco group, a widely used classification system. And of course, the corticospinal tract. And how common are these gliomas? Well, the incidence of diffuse low-grade gliomas is about 1 per 100,000 individuals per year. And numbers from our Scandinavian group with this publication in neurooncology practice shows that gliomas are presumed to be in aneloquent areas in about 2/3 of the cases. And we also see that the frontal lobe is one of the most common places for diffuse gliomas. So a glioma in or near motor areas is quite common. And for the diagnostic workup, well, there are a lot of elegant non-invasive functional mapping techniques, mainly functional fMRI and diffusion tensor imaging, that we can use to try to localize these eloquent areas preoperatively. But one of the more useful methods to try to map preoperatively is also the navigated transcranial magnetic stimulation. And this is all important to try to preoperatively do a risk assessment and a surgical selection and for the patient counseling. So an fMRI, as you can see here, can show you in the upper images motor localization of, for example, the motor areas, primary motor areas for the leg, and on the lower panel in blue for the hand. And we can also see a supplementary motor area where this presumed diffuse low-grade glioma is residing in the supplementary motor area and would be expected to come close to the corticospinal tract. And there is actually an interesting publication as early as in 2007, a prospective randomized controlled trial where they could show that for the patient that did a DTI-based pre-surgical planning, they had lower rates of neurological deficits. But for the TMS, it's an mapping procedure, non-invasive mapping procedure, where you can evaluate motor representation, and you can use these results to integrate it into your pre-surgical planning. And here we can see an image from the navigation system where the points from the NTMS has been used as an object, and we can see that it resides close to this presumed diffuse low-grade glioma in the right frontal lobe. And these points from the NTMS can also be used for seeding for the tractography. So it gives you a lot of imaging in not only the preoperative planning, but it can guide your intraoperative mapping. And we know from this publication, which is probably one of the most cited publications, where it's a pooled meta-analysis of the importance of mapping for not only the extent of resection, where you can see that the extent of resection was much larger for the cohort that was mapped compared to no mapping, but also a lower frequency of permanent deficits at 3 months. And this is pooled results from more than 9,000 patients. So for the surgical management, we use the common techniques that we also use for non-eloquent tumors, well, neuronavigation, and we can use intraoperative MRI, intraoperative ultrasound, or even 5-ALA to have an as extensive resection as possible. But when it comes to safety, it's necessary to do some kind of intraoperative neuromonitoring and mapping. And if you're thinking about these intraoperative neuromonitoring techniques, they can be divided in two. It's the mapping, which is useful for identifying the functional sites when you're trying to localize where the eloquence is. And then you have the monitoring, where you want to try to assess the integrity. You know where the tracts are, you know where the cortical areas are, but you want to monitor them during surgery so they don't get damaged. And for the mapping techniques, well, looking for localizing the central sulcus to define the primary motor areas. And then we have the phase reversal, and we will go into more details in the case that I will show you in a minute. And then you have direct electrical stimulation, cortical or subcortical, and different direct electrical stimulation techniques, the low frequency or Penfield technique, usually done with a bipolar probe, or a high frequency frame of 5 with a monopolar probe. And there is no real consensus of superiority of one technique over the other. To assess the integrity of the tracts, it's mainly motor evoked potential, either transcranial or transcortical. And should we do these surgeries asleep or awake? Well, there is no consensus on when to use awake mapping or asleep mapping for motor area gliomas. But this review, quite recent, published in 2022, did not find any significant differences. Last year, Defoe and his group published a systematic review and meta-analysis where they did see some advantages of awake mapping with higher return to work for the patients when operated awake, and a little bit lower risk of permanent neurological deficits. But it's generally much about the preferred routine at each center, so to say. But to jump into the case, this is a patient with a classic history of epilepsy, and the MRI shows these quite extensive 6 centimeter in largest diameter non-contrast enhancing tumor, which seems to be residing mainly in the premotor area, if you look at the cortical structures, but is touching upon the corticospinal tract. And since this patient did an fMRI, right-handed patient, fMRI and TMS confirmed non-dominant hemisphere, so we did not have to do any speech mapping, and we regarded it as a motor glioma. So we did the preoperative mapping to get the points for the motor areas for the hand, and here you can see the muscles tested. It's the abductor pollicis brevis. I suspect that you are reading the Swedish text here, but it's the common hand musculature, and extensor digitoris communis primarily. And the TMS points we then could use as an object and a seeding for the tractography. Jumping into the OR, we have an integrated OR where we use all this information in the navigation system and augmented reality in the microscope. But we are very grateful for our neurophysiologist, which you can see there in the background. So we usually start with a baseline MEP cortical to just have a monitoring of the integrity of the corticospinal tract. But as you might know, that through diffuse low-grade gliomas, it's not that easy to see what's a tumor and what's a healthy brain. And we usually try to localize the central sulcus here with a phase reversal. And for those of you who are not familiar with the technique, it's a stimulation of the median nerve that we are looking for the SEP answer or the SEP signal, so to say. We record the signal, and the electrodes post-centrally record an upward deflected signal, while the electrodes on the precentral gyros record a mirror image with a phase reversal of the SEP. In this patient, this was not that, it had a little bit disturbances, but it was between the electrode 4 and 5. From this patient, it is even much more obvious. So then we have localized the central sulcus, and we can start with a cortical stimulation. And you can see on the image from the microscope that in green, we have sort of outlines from the object from the TMS. And this could guide to start quickly a direct cortical stimulation, confirming the motor responses for the hand. And then we put this strip electrode to be able to do a continuous MEP to assess the integrity. So we could have the border for the resection, and coming down through the sulcus, we started direct electrical stimulation again to see how close we were coming to the corticospinal tract. So there you can see in the right hand a monopolar probe where we are stimulating, and we were getting responses saying that we would be about 5 to 10 millimeters distance from the corticospinal tract. So then we just continued with removing most of the tumor in the anterior part to get the whole bulk out, and do the fine tuning a little bit later. So we will see if we can speed this up a little bit, which you sometimes wish you could do. Yes, that you could see that now we have removed the bulk of the tumor and going down to doing not only testing the integrity, but also stimulating with the monopolar probe in the right hand and using the sonopet or ultrasound aspirator. Here we have the loss of signal coming down to 3 milliamperes. So we had a response with 4 milliamperes, meaning that we are a few millimeters from the corticospinal tract. We were happy with that, and also happy to see that the pre- and post-operative maps were unchanged, and this was the post-op MRI 24 hours later. However, as you might wonder, the patient was having some severe symptoms, left-sided hemiparesis on the first day, reduced muscle strength, more in the leg than the arm. Already on day 4, it was improving a little bit and almost completely recovered on the 21st day. So this was a classic SMA syndrome. And when operating in such eloquent areas, it is quite common to have new neurological deficits. These are data from the large German group, but severe permanent deficits we, of course, are trying to avoid. And data from our low-grade glioma Scandinavian database, we also expect to have a lot of transient deficits because we are coming so close to the tracts, but we don't want to see the permanent deficits. And they are, the motor deficits are the most common. And this is an interesting paper that I would like to mention from Francesco Sala's group. That we are well aware that even though we have intact MEPs and they are preserved intraoperatively, some patients will still have deficits postoperatively without having had any disturbances preoperatively or intraoperatively. And the reason for this might be that we are not during the asleep situation able to monitor the SMA or the premotor areas. And when they did their sub-analysis on this patient, they could see that these MEP unrelated deficits occurred when the SMA was resected in conjunction with dorsal premotor regions. So this could be an argument to do awake surgeries to try to avoid this. So to conclude, for motor eloquent gliomas, maximum safe resection is recommended. To increase safety, pre-op and intra-op mapping is, I would say, almost mandatory, but we should not forget that there are patients that will not benefit for surgery. So if a patient has several negative prognostic factors, maybe it's the right thing to just go for a biopsy. Thank you for your attention.
Thank you, Margaret. We carry on with the topic of gliomas, and our next speaker is Rachel from Israel talking about insular gliomas.
Good afternoon. I will talk in the next few minutes about surgery for insular glioma. I think that this is one of the most challenging topic in neurosurgical oncology, because when we deal with the insula, we need to be aware to the fact that the insula is fully covered by the temporal and the frontal operculum, and it's a very functional region. And it is very close to the MCA branches and to the lenticular striate. So the insula is divided by the central sulcus, the same central sulcus that divide the parietal from the frontal gyrus in the upper side, but In the insula, actually, the central sulcus divide the insula into the anterior lobe, which is composed of 3 short gyrus, in the posterior lobe with the long gyrus. And here you can see the coronal cut in the level of the insula. You can see the internal capsule and the insula, the superior limiting sulcus in the upper side, and the inferior limiting sulcus in the most lower side. Here in the most superior part of the insula, you can see how the insula is in the actually the most close point into the corticospinal tract, and this is the point where the corticospinal tract is mostly susceptible to iatrogenic damage. So this is a kind of a zoom in on the insula. Again, you can see the central sulcus, which divide the short gyrus from the long gyrus, and the central sulcus actually intersect with the superior limiting sulcus in the upper aspect of the insula. And in the lower part, you can see the lumen insula in the anterior inferior part of the insula. So we need to be aware to the white matter tract in the area of the insula, the SLF and the arcuate fasciculus going around the insula, and in the axial cut below you can see the internal capsule and the external capsule just medial to the insula, and the basal ganglia and the gray matter structures such as the putamen and the thalamus, just medial and deeply located to the insula. So the green bundle that run just encircle the insula is the SLF. And here in the coronal cut, you can see the green dot of the SLF. And the important issue here is to be aware of the fact the SLF is just medial and superior to the insula, means that if we operate in the region of the insula and we're going just out, medial and just superior to the area of the insula, we can definitely damage the SLF. Also, we need to be aware to the corticospinal tract, just going medial and posterior to the SLF from the M1 all the way through the corona radiata, internal capsule, and the brainstem. And again, when we operate in the region of the insula, we have the basal ganglia that separate between the area of the insula and the corticospinal tract. However, the area that is mostly susceptible to iatrogenic damage during surgery is the superior part of the corona radiata, where we don't probably meet basal ganglia before the corticospinal tract. So the IFOF deal with semantic processing together with the uncinate fasciculus and the anterior commissure and the optic radiation. All of these running as a group of white matter tract through the temporal stem, which actually is kind of a white matter tract bridge between the temporal lobe and the basal ganglia. We need to be familiar with the vascular anatomy, which is extremely important when doing surgery in the insular region. The lenticular stride that originated from the medial part of M1, piercing the anterior perforating substance, which supply the putamen, the internal capsule. We're talking about between 2 up to 15 small tiny vessels, up to 1.5 millimeter of lenticular stride, small end arteries vessels. And if we damage such a small tiny artery, we can cause lacunar stroke and severe morbidity. So for a long time, the insular region considered as very dangerous for any surgical treatment. And the accepted treatment usually tend to be biopsy or wait and see in case of low-grade glioma. However, over the past 2 decades, we have more understanding of the molecular profiling of this kind of tumor. And especially we understand more and more the association between maximal resection and better prognosis. And we are talking, generally speaking, in a low-grade and high-grade glioma, also when they are located in the insular region. So I think that we can speak about a kind of a treatment, shifting in a treatment paradigm to more aggressive and radical surgery aiming for a maximal and safe resection, even when we are dealing in a tumor located in the insular region. So it's not that rare pathology. In case of a low-grade glioma, up to 30% will be located in the insula, not just pure insula, but involving the insula. 10% of the high-grade glioma will be located in the insula. They tend to have better prognosis, and the typical patient tend to be a young patient with low-grade glioma, presenting with a seizure, and considered as an intact functionally wise. So if we're talking about the morbidity in a tertiary high volume center, usually it's up to 11% of major morbidity. There are several classifications of insular glioma. The first one was published by Yassergil in 1992. And 15 years later, Berger and Sinai published their classification of insular glioma. They divided the insular region into 4 zones, the Sylvian-Fisher axis and perpendicular line in the foramen of Monroe axis. And this 4 zones describe different zones that each one correlate with the ability to perform extent of resection in the insular gliomas. However, we know today that there are much more other parameters that correlate with our ability to perform extensive resection, and we are talking about the texture of the tumor, suckable tumor versus a firm tumor. The tumor is a highly infiltrating tumor, has very sharp margins. Are we talking about low-grade or a high-grade glioma, involvement of the lenticulostriate? All of these parameters will affect our ability to perform complete resection or just a subtotal resection. There are 2 major approach to perform surgery to insular glioma, and I'm talking about the Trans-Sylvian approach, which is the classic approach described first by Yassergil, versus the transcortical approach that sometimes it be the better approach, and sometimes the better approach will be to combine both Trans-Sylvian and transcortical. For transcortical, we need to be able to map the frontal temporal operculum and to perform the corticotomy, kind of a cortical window, and to get into the tumor. Generally speaking, probably will be better for the posterior part where the dissection of the Sylvian-Fisher is more challenging. So this is just an example of an insular glioma, low grade. And we perform here a transcortical approach. We use the CUSA, the electrified CUSA, And we know in every time point our distance for the corticospinal tract. You see how we preserve the small tiny vessels. And this is the, and this is the post-operative MRI. So when we approach insular glioma, we need to be aware to the difference and to the nuance between insular tumor, dominant versus non-dominant tumor, whether we're talking about a high-grade glioma versus low-grade glioma, well-delineated tumor, sackable tumor, involvement of the lenticulostriate. All of these parameters are highly important. So this pathology is not that rare, and surgery is the preferred treatment modality. And we know that maximal resection is associated with better progression-free survival and overall survival. We can approach it to Transylvian or a transcortical with intraoperative mapping and monitoring. And I think that bottom line, we need to remember that we need to choose the right strategy for each patient. So I will stop here and thank you very much.
Thank you, Rachel. We continue with the topic on gliomas, and the next talk comes to us from Italy, and it will be Silvio talking.
Thank you, Christian. Thank you to you and the neurooncology section of the EANS for inviting me. I hope you are looking at my presentation now. So good afternoon, everybody. I will try to show you quickly something regarding a modern way to interpret awake craniotomy and trying to going beyond how and when to use awake surgery, which are the advantage of this technique, how to improve awake surgery, how to give you some pillars regarding the kind of mapping that you can obtain and showing you some results. So the community accepted the fact that regarding the grading of intrinsic glioma, the resection is still now the most important factor impacting the overall survival of our patients. And we understood after a growing amount of evidences that the preservation of the brain architecture is crucial to obtain the best functional outcome in our patient. We understood that, and we understood that also that pushing the resection even in the high-grade glioma sometimes and whenever possible beyond the contrast enhancing area is something that advantages our patients in the overall survival. And in fact, we are changing our concept now of gross total resection, and we are trying to define some threshold regarding low-grade and high-grade glioma, residual tumor, and also threshold regarding the potential effects, especially for higher functions impacting the cognitive assessment of our patients. And awake surgery is probably one of the most debated topics now in neurosurgery. And why? Why? Because we entered in the so-called connectome era. And you know, a lot of people use this argument regarding connectome, but we still we did not yet know exactly what we are discussing about. What is absolutely and definitely true is that we have to adapt our concept and our knowledge of the brain to neurooncological surgery. To do that, we have more and more instruments, this kind of instruments like cartography, and especially particularly tools that are dedicated to a neurosurgeon. Tracking, for instance, as cluster-based for neurosurgeon is very useful, is very didactic, and is particularly useful, especially for younger neurosurgeons. We are We have tools that allow us to perform virtual microdissection that improve our knowledge regarding the main pillars of the architecture of the human brain. We have the functional imaging and particularly resting state functional MRI that is very easy and you can perform every day in 10 minutes in your hospital and to elaborate this in your office, trying to have a sort of prediction of what will be your surgery and eventually your mapping if you will choose awake surgery for different networks like sensory motor, visual, language network that you can map and you can verify intraoperatively at individual level. And we're having more and more information also regarding the plasticity of the brain by this tool. And so to adapt also our strategy, how of which kind of patients is better to reoperate or to operate under awake surgery because I have or I had or I did not have a reorganization of which patient to be selected for awake surgery because I already know that, because I can have a prediction of the fact that these patients have more risk to have attentional or cognitive deficit before the surgery. And then we don't have to forget the fact that awake surgery improved our knowledge of the system. And now, thanks also to the integration of multimodal data, including resting state, direct electrical stimulation, and other tools, we have unprecedented reliable atlases at population level, demonstrating a very good correspondence with the 90% of the patients that we are planning to operate. So we have a lot of tools that can improve our selection criteria for awake surgery and can predict our potential goal in terms of resection. How to use this? So I will try to give you just some pillars regarding the language processing and the higher cognitive function, because this presentation will be longer and longer otherwise. So you know that we almost defined what is the skeleton of language processing. So we have a sort of dorsal pathway dedicated to the phonological elaboration and to the speech articulatory planning. And we have a ventral pathway regarding the dorsal way. So arcuate fascicle and superior longitudinal fascicle, this is very easy. You can ask to your patients, for instance, to count within the theater. And if you look at the distribution of this kind of errors, you will see that this kind of function is strongly localized between the parietal and frontal opercula. We knew since now many years that we have a direct connection observed by the most ventral portion of the superior longitudinal systems, and we have an atlas also of the speech articulatory network that finally was proposed also in investigating the negative speech arrest points in a larger series of patients. So we have many information about this hemispherical network to prevent deficit. We know that it's very plastic, and so it's very easy to be mapped. The same for the phonological network. It's simply object naming task can drive you to find some phonological error that you will find in all the white matter around the insula between the frontal and the temporal region. This kind of connection, is constituted by the arcuate fascicle, probably one of the most known bundle in the human brain. One century ago, it was described. This is of course, a multi-layer bundle with many different functions, but it is a crucial area of this bundle at the temporoparieto-occipital carrefour that is the stem of the AF that is crucial for phonological processing and is another pillar of the intrinsic brain mapping. So what about the semantics? Semantics is totally the contrary. So you can, find semantic processing error just providing to the patient, just proposing to the patient an object naming task. And you will find this kind of response in the deep white matter running between the occipital, the temporal, and then through the external capsule within the deep and posterior frontal lobe. This is in fact the course of the mainstream of the ventral system, the IFOF, the longest bundle in the human brain. IFOF is crucial for planning surgical resection within the temporoparieto-occipital, insular, and frontal lobe, because this is a very long bundle, but especially for its funding area within the stem of the external capsule, and particularly at the level of the anterior third of the external capsule. This is in fact the limit between the insular subcortical tissue and the external capsule, and then the anterior perforate substance area. You know that IFOF is crucial also for preserving patients from myopia, because all the course of the optic radiation is covered by IFOF. So mapping IFOF on the left or on the right using a PPTT test allow you to preserve the superior optic radiation, so to induce just a quadrantopia to one of your patients. We don't have to forget that movement is not just movement. So we have the movement planning. So be careful when you plan a resection in the precentral area. Planning a resection in the prefrontal area means that you have to assess exactly the descendant pathway from the SMA to the striatum that give you a totally different response. You can see with a totally motor and verbal arrest because of the activation of this cortical-subcortical direct connection. This is totally the contrary in case of resection of the precentral area running from the dorsal to the ventral frontal region, because you see in this kind of white matter in this region, the white matter is particularly dedicated to the surgical planning. And in fact, when you go to stimulate here, you have a totally different, even if the region is similar, you have a totally different response with the stuttering, but no motor block. This is due to the fact that we are not stimulating more the descending fiber, but this transverse system connecting the SMA to the ventral premotor cortex, the most ventral part of the precentral gyrus. Frontal atlant tract is a crucial structure, for instance, for motor planning in language functions, and in fact, impacting and disrupting fact drive your patients to experience dramatic problems, troubles in the phonemic or semantic fluencies. What about the spatial perception, for instance? You know that this is a strongly right localized function, and this is crucial to map this function when you plan resection in the parietal, superior parietal, but also inferior parietal level, but also at the level of the middle frontal gyrus, because you have to remember that the frontoparietal network is it's a strong connection between the frontal lobe and the parietal lobe, and particularly the frontal lobe, the frontocyphid region, that in fact drive our spatial orientation. Where we are going to trying to monitor more and more functions, not to map, because there are some functions that we cannot map, but just monitor. This is a wonderful paper from Luca Zigiotto from our group, recently published in Neurosurgery, in which we tried to explore attention of working memory troubles in patients submitted to resection of low and high-grade glioma. What is interesting was not just the survival curve of the weak surgery, but especially the functional results that demonstrated that larger resection in the frontal area involving the posterior cingulum, the most mesial part of the posterior cingulum, drive the patient to experience major attentive troubles. And we also reconstructed this minimal, common, and crucial attention network. So this is a function that we cannot map, but we can monitor. In fact, this paper, and the most important result of this paper, I think, is the fact that using a dual task, so movement of the superior limb and verbal production or object naming together, and Stroop tests are reliable to preserve attentive and working memory function. So here, just a few cases to show you a simple resection in the temporal region, in which you see we performed the supratotal resection going in contact with the fibers of both AF and IFOF in the depth. So we reach some CC of tissue more not impacting on the cognitive output. Some of our patients, you see here a larger and larger resection in the frontotemporal insular region of this big grade 3 astrocytoma, in which once again you can see the reconstruction of stratigraphy with spherical deconvolution of the different bundles that are totally preservated. And in fact, the most important use of stratigraphy, in my opinion, is just to orient you on when you can map which kind of patient really you have to candidate to awake surgery. This is the same for this pure low-grade glioma of the post-central gyrus, in which we stimulated the hand at the somatory sensor primary pathway. This is the only way to map this kind of function. And you see in the end, all the fibers of the posterior thalamic radiation that were mapped and preserved with a total removal of the tumor. Or once again, a big high-grade glioma, insular high-grade glioma with a totally preserved IFOF in the depth. You see here this high-quality stratigraphy showing the course of the IFOF in the depth of the external capsule. So once again, we mapped until reaching our results without splitting the Sylvian fissure. So my final remark is just to tell you that please don't choose a school. Try to choose the best technique for the best patients, and try to improve your knowledge about the system with a lot of tools that we have: functional MRI, stratigraphy, microdissection, atlases, papers and papers and papers that in the last 20 years improved our knowledge and our results. Thank you very much.
Thank you, Silvio. And now we go for our last talk about pineal tumors coming from the UK. Tina will be showing us insights on pineal tumors.
Thank you, Christian, for inviting me. I'll just wish to touch upon not equally challenging. Sorry, let me just start my presentation. Equally challenging topic. Please do let me know if there is any problem with my microphone, because I know there were some issues with Silvio earlier. So please do let me know and I will adjust. Are you able to view my screen?
Not yet.
Apologies. Oh. What happened there? Are you able to see now?
Yes.
Okay. Okay, is it okay now? And can you hear me and can you see my slides?
Yes.
Fantastic, thank you so much. So yes, pineal tumors is subset of tumors that we all, I guess, approach, at least I do, with trepidation, and I have still been doing so, even I've been now doing them for more than 18 years. The pineal gland is a neuroendocrine organ, which is actually quite small. So it is, I'm surprised to find out that it weighs only 100 milligrams, but it can cause so much anxiety. And it has been known from the ancient times, mentioned by Herophilus and Galen, which thought that the soul arises from it kind of flows air from lung and heart to the brain, and the pineal is kind of modulating all that. Again, it has been called the principal seat of soul, or the third eye, and it comprises of pinealocytes and glial cells. What does it control? To be honest, it's secreting melatonin, and you'll see patients have complained of sleep disturbances, and it can affect the circadian rhythm, but we are not still very familiar with its exact functions. Pineal tumors are quite rare, and they comprise only of 1% of all brain tumors, and as I said, I mean, they are really rare. And I remember one of my patients asked me how many of those have done it. I said, at that time it was, I said, 25 only. Now I'll go to someone else. I said, please do. So they are quite uncommon. And even for us at we're a big center, and we do more than 450 brain tumors a year. Sorry, are you still seeing my screen?
Yes,
Hello?
we
Yeah,
can see
sorry.
your screen.
Yeah, okay. And even for us that we do a significant amount of cases a year, still there is less than 2 to 3 cases per year. They're more frequent in children, so I'll say for the last few years of my career, I'm not doing pediatric neurosurgery, but only adult. So maybe people who do pediatric tumors have a bit more experience. They are predominantly affecting males rather than females, and have increased incidence in Japan and Korea, and predominantly germinomas. The mortality, it has been considered high-risk surgery, and the mortality has been reported 4 to 8% in different series. Most of the tumors in the pineal are pineal cell tumor origin, with a majority being pineal tumors of intermediate differentiation with variable prognosis, pineocytomas, which are more, and papillary tumors of pineal origin, which are kind of more benign, pineoblastomas that are other aggressive, and then there is a big section of germ cell tumors that some of them are positive for tumor markers, and we'll talk on that in a minute. And then you can still find some other types of tumors, such as glial cells, such as pilocytics or GBMs, angiomas, and metastases more early. So that's a typical example of a pineal tumor of intermediate differentiation. And the majority of patients do present with hydrocephalus. And visual symptoms. They complain of diplopia parinodes, and depending on the extent of the tumor, they may have other variable symptoms. How do we investigate? Usually the patient will come with hydrocephalus, as I said, and I would advise to do an MRI brain and spine at the same time, because you may have seeding such as in pineoblastomas or pineal tumors of intermediate differentiation or germinomas. And then tumor markers in serum and CSF are very important, as in particular alpha-fetoprotein and beta-chorionic gonadotropin, because obviously that will determine how you will approach the tumor. Even if you have, CSF is more sensitive than serum, but if you can have absence of tumor markers, you should interpret that cautiously. As I mentioned earlier, it's important to do a spinal MR, because this is a case of pineoblastoma that we had seeding in the spinal cord. That was actually sometime later after the original presentation of the pineoblastoma. So the first thing we need to do for these patients is to manage the hydrocephalus, relieve the pressure with treatment of choice, endoscopic third ventriculostomy, which allows not only to inspect the ventricles for CSF dissemination, do sampling of the CSF, and biopsy first. If possible, if possible, do the ETV first, because if you do the biopsy, you may have bleeding, and you may not be able to do your ETV afterwards. Sometimes, obviously, depending on age of the patient and the suspicious and possible markers, you may need to do that. So this is a bit of an algorithm how your line of patients to present with a primary tumor and CSF direction procedure, first and then depending.
Excuse me, Tina.
Yes.
We have now a different issue. We have now like somebody else. It sounds like somebody else is on with the microphone, but there isn't.
Saying something to see.
No, it's gone. I'm not sure. I'm not sure what this is. Please continue. I'm sorry to interrupt.
Thank you. So, so this is how we, that's the algorithm we would follow depending if you have hydrocephalus or positive or negative markers. And if you have positive markers for germinomas, teratomas, then you go for straight for oncological treatments. In the past, I have seen, when I was training, I have seen colleagues doing stereotactic biopsy, but I have seen some catastrophic events from a biopsy from venous damage, so I wouldn't advise that. My treatment of choice would be to do an endoscopic biopsy at the same time of the ETV, either with 1 or 2 burr holes. I'll just go to this. So this is an example of a case where we had to do 2 burr holes. So you do your burr hole for the you can plan your trajectory with neuronavigation for the endoscopic third ventriculostomy, and then do a more inferior burr hole to access the tumor, so we can plan 2 different trajectories. Again, sometimes you may have to go on the contralateral. You can do contralateral burr hole if your tumor is eccentric, and our pathologists don't like cauterizing the tumor if possible, because you may get a suboptimal result. Okay. Coming to the patients that need surgery, there are at least 4 approaches that are well recognized, and one has to be guided their approach by the extent of the tumor and its location, its anatomy of the veins, the angle of the tentorium, but most importantly of the surgeon's experience and preference. My preference for many years had been an occipital transtentorial approach, infratentorial supracerebellar approach, which, as you see later, I have been more familiar with, but more recently in our center, we have moved to lateral supracerebellar approach, having a younger, very talented colleague, Pietro D'Urso, who is very keen on that, and we do them jointly. As per other pathologies, unfortunately, there are not many technological adjuncts who help with accessing the tumor other than knowing your anatomy very well. And before I do pineal tumor, I'll go back to traditional, Roton textbooks and things like that, and read my anatomy. And for me, that has been the easiest approach, the infratentorial supracerebellar, because you can kind of depress the cerebellum and you go straight in there. You can see the vein of Gallen, and then angle your microscope down, open the quadrigeminal cistern, and the tumor is at the center of your approach. So the veins usually are displaced anteriorly, so it makes safer. Obviously, the patient is in concord position, so for the surgeon is can be quite painful standing there with your arm stretched. So you require a lot of stamina and resilience. And there is always the question: should you or should you not coagulate a precentral cerebellar vein? Could you give infarct to the patient? Some surgeons advocate endoscopy. In experienced hands, we use a lot of neuronavigation and ultrasound as we progress through the surgery to see how much tumor we have resected. Some kind of disadvantages: you may need to retract the cerebellum quite a bit, and it may not be suitable for tumor that extend superiorly or laterally, or if they displace the veins more ventrally. So the other way. So occipital transtentorial approach, I've used it only on very few occasions. Then the risks with that is that you go in an oblique way, so all the structures are on the side. And in my hands, we had, I think, 1 or 2 cases where the patient developed hemianopia from retracting of the occipital lobe. So I would advise if anybody, if there is an indication to do that, to use an EVD or some other measures to lower the pressure to avoid visual field defects and venous injuries, or the other way. That was one case of a mature teratoma that we did by this approach, and then some interoperative images towards the end. And seen here, so I just wanted to show you that it's quite a sharp oblique angle where you have the vein of Rosenthal and vein of Galen on the side. Transcallosal hemispheric, I don't have an experience on that. It has been reported, but I have not done any cases posterior transcallosal. I'll just give an example here. This is a case of a 44-year-old lady who presented with hydrocephalus. We did an ETV and we did, the CSF was negative, and we approached it through a lateral supracerebellar approach. So this is a small craniotomy, laterally depressed the cerebellum, open the arachnoid, and then down here to the pineal, and that was it was a pineocytoma, and that was her post-op scan. Sometimes you may have to combine approaches. So this was a patient that had presented with this quite extensive tumor. So I had to do 2-stage operation, infratentorial supracerebellar and transvermian to resect the tumor. And that was a pineal tumor of intermediate differentiation, had radiotherapy. He's still here with us, I think 9 years later. Some other pathologies, you can see the cephalocytic astrocytoma that has bled. You may have meningiomas, GBM. So that is our experience, and I'm saying our because we do those jointly with my colleague Pietro D'Urso the last few years. I have 32 patients the last 10 years with a mean age of 29.5. The majority presented with hydrocephalus, and we did 28 open surgeries. As I said, initially were supracerebellar, infratentorial, and most recently we moved to lateral supracerebellar. I had one mortality intraoperatively. I must say that was one of my lowest points of my career. Everything was going very well, and suddenly the pineal tumor became all black. There was no vein damage, but the patient had an infarct, and the postmortem showed pineal apoplexy, all the veins intact. I believe it was a very rare thing, but it actually made me quite anxious operating again. We had a couple of CSF leaks, 2 infections, 1 cavity hematoma. That was a GBM patient that he improved following an EVD insertion. So that was our different pathologies. As I said, the majority are pineal tumor of intermediate differentiation and some pineocytomas. There are not many series out there, or many big series out there. I found one of the biggest series of 68 patients, where again the report, the gross total resection was 52%, and these were the overall survivals and progression-free survivals. So following our surgery, some tumors will need to have radiotherapy and chemotherapy. As we know, germinomas are highly radiosensitive, and more recently in the UK, it has been approved to stereotactic radiosurgery for pineal tumors, but mainly the ones that have recurrent and progressive residual disease, but are not suitable for further surgery. We have used that for a couple of times, and also proton beam. So pineal cysts, it is a bit of a, I think all of us will see a lot of patients in clinics that presents with pineal cysts, and patients have non-specific complaints. Very rarely will operate on them unless if we are absolutely convinced that obviously they have symptoms of, either we had a couple, one had hydrocephalus and one had an episodes of recurrent loss of consciousness, which we couldn't explain otherwise, and thus improved post-operatively. So in our experience, despite the risks, radical surgery is effective and safe, but can be considered for patients, but you need to, I guess, acquire experience over time. There are some considerations here. It is a low volume, high complexity surgery. This is something that is very topical in UK neuro-oncology world right now. And the questions are, how many surgeons should we be doing? Should we have networks? Should we have national MDTs? So this is ongoing discussions. In our unit, we decided that for most of these cases, we'll be doing 2 surgeons because, to be honest, it takes the pressure away, and quite often these are long operations. As I said, patients will ask, how many cases you've done, but I don't know if anybody can give the answers, how many surgeries you have done, you should have done to qualify. But all I would say to people who start early, it's very good to know their anatomy very well, maybe do cadaveric dissections, anything you can, and also get some experience from pediatric neurosurgeons. And it's good if you work in any department to have good links with teenage and young adult services and access to proton beam treatments. So yeah, I would like to thank all my colleagues who trust me to do these cases, and my colleague Pietro Durso, with whom we do the cases together. And thank you, Christian, for inviting me.
Thank you, Tina, for your talk, and thank you to all our 4 experts for your amazing talks. And it seems like they are very comprehensive, because up to now there are still no questions in the Q&A, and I'd have a lot of questions to all of you. And so will Jiri and Matthias probably. So who wants to start?
If you want, if nobody else wants, I can. I have a question for Margaret. What is motor eloquent? How do you define that? I mean, for obvious reasons, deficit rates depend on how close you are to the, for example, corticospinal tract and so forth. I found that difficult to answer when reading papers. What is motor eloquent? Is there a definition? What is a way to get to a definition?
Thank you for that question, Matthias. And I am honored that you think that I might have the answer that is so difficult to read out of papers. And it is challenging because we don't have a consensus on when the tumor is really motor eloquent, as the case I showed you was not residing in the primary motor cortex, but it was touching upon and coming very close to the corticospinal tract. It was a definition of a motor eloquent tumor. So I would say that if you, during your resection, would be close to either the primary motor cortex or the corticospinal tract, it's definitely a motor eloquent tumor. And then the paper that I mentioned in the end from Francesco Sala's group, where they showed that you could still get motor deficits even though you had no signs of damage to the corticospinal tract, just shows how complex the case is with all the supplementary motor area and premotor area as well.
Okay.
So I'm sorry I can't give you a better definition.
Maybe somebody else has an idea or a suggestion. I don't have one. I really would like to learn. An operational definition whenever the surgeon considers the motor pathways to be at risk.
Very difficult.
I think everybody is thinking the same. So it sounds a little bit like what eloquent is what I say it's eloquent.
Mm-hmm.
And this is what I can task. But like Silvio, what puzzles me a lot in awake surgeries is how do you choose the tests you use intraoperatively, and for example, especially how do you choose the amount of tests that you can test your patient with? Because my idea is sometimes you have with such an awful lot of tests, this will extend surgery and probably also alter the surgical results. So how do you choose which test, when, and how much the patient can bear?
Look, Christian, what I said in the talk is exactly what we do, So very easily battery of tests. So all our patients, and what I suggest is to perform an extensive cognitive assessment before the surgery, just to understand in which kind of domain the patient is more or less, performant. And I especially refer to the trial making test and to the attention and memory, because, during surgery, the patients can have some problem to perform a dual task. But regarding exclusively the task during the surgery, we have a very easy and reliable protocol. So object naming, for all the cases in which we have dorsal or ventral pathways involved in the resection. If we are on the non-dominant, non-specialized, hemisphere for language, so most of the time on the right side, we use the PPTT instead of the object naming. This is just because, it's a sort of higher testing of the semantics, the so-called nonverbal semantics, and then a continuous upper limb flexion extension that is dually performed all over the surgery. And, the last paper I showed you regarding attention and memory is crucial, because for the first time, we assessed that in the big resection all over the brain, performing a dual task and performing a simply Stroop test is reliable in order to predict a permanent deficit in terms of attention. So for last, the Stroop test, and then the counting for, the localization of the speech articulatory network, that most of the time is just to set the threshold and nothing more. Okay, we change it for the spatial cognition on the right side in the parietal lobule, as I showed you, the bisection line that is very difficult to perform in the surgery for the patient, with the Milner test. I don't know if you never look at this kind of test. It's a red and black line, and the red one can be longer, or the red one or the black one can be longer, and the patient said black on the right and red on the left. That is, it's very easy, but so easy task, totally tailored in reference to the anatomical region we are approaching. And so this is crucial for me to have a good preparative planning on both the side, functional with the resting state and structural with tractography, with the performance tractography. No neuronavigation, this tool for tractography reconstruction on neuronavigation and so on. Try to perform this by yourself. We have a lot of tools to do that and to set so no saxophone or guitar or, Olivia Scolane or something. It's like some colleagues.
Silvio,
Iri,
in case
please.
of an insular glioma, what kind of tests do you want me to do for the insular resection?
Yeah, for insular resection, on the left side, so in
Yes.
the dominant hemisphere for language, we start with the speech arrest, okay, just to identify the ventral premotor cortex. You know that most of the time the tumor involves the opercula, but if not, we test, but never we have this kind of big trouble in the pars opercularis, and especially in the dorsal pars triangularis. That is crucial for the subpial approach to the insula with an object naming, and then object naming and continuous upper limb flexion extension until the identification of the IFOF stamp, and then resection of the insular tumor, nothing more. Object naming is not a long test, and the patient has some adaptation to that. So sometimes we switch between object naming and PPTT. That is good also on the left side, or spontaneous speech also, just to change the attention of the patient, to change the task, but nothing more, nothing special more.
Thank you.
Iri?
Yeah, I have a question actually for Margaret and Rachel. I like your talks a lot, and I was just thinking, so let's say that you are a younger neurosurgeon and you're interested in neuro-oncology and you know some anatomy and you know some monitoring, right? So what would you two recommend one to do if one wants to advance further? So basically the question, know your anatomy or know your monitoring? What's more important in your opinion, your two's opinion?
You want to go first, Rachel, or should I try to answer this?
Whatever. So I think there is a real life experience, and I think more and more hours in the operating room, and then you deal with everything because there is no sterile environment that you deal just today. I will deal only with anatomy, and tomorrow the other. So I think you usually start with more simple cases with less potential morbidity. And then you experience to get closer and closer to the eloquent region, and then in case you succeed, you have more confidence to the next case, and then you dare to do more. I think this is the way by gain experience. So.
Yeah, I do agree that you should start using monitoring not for the cases where it's really critical and when you have a tumor that's more or less in the primary motor cortex or diffusely infiltrating the corticospinal tract, but using the technique to get used to it in the cases where you're not absolutely well dependent on it. And as Rachel said, volume. So team up with a more experienced surgeon and a fellowship, for example, or something like that would be good to try to get exposed to as many cases as possible.
But if you're, let's say your boss tells you, okay, you have 2 hours per week that you're allowed to do something else than your clinical work. You can either spend the 2 hours in the anatomy lab or you can spend the 2 hours with the neurophysiology colleagues.
Can we split
One
it?
and one.
I would split it.
Split it, that's a very diplomatic answer. I like that one.
I would try to get a new job.
Even better.
Yeah, I think you need to be familiar with everything in the end of the day. You need to be versatile. You need to be able to use many options and to be able to choose the right one for the specific patient.
I may add, if I mean, as Margaret said, doing a fellowship in a center where they have a lot of experience helps because you build up your confidence and you see also what works, but also the pitfalls. So I think that would be.
I have a final question for Tina. You said that you changed your approach to the pineal region over time towards a more lateral approach. And I think this is always very difficult to choose the perfect approach to a lesion. So first of all, why did you move to more lateral position, and then how you generally decide which approach to take of the 4 you showed us?
Yeah, I think a lot has to do with, as I said, the anatomy and kind of relationship of the veins to the tumor. The reason also we moved, I have to say, because my colleague who joined earlier is more into more minimal invasive procedures, and we're trying to do smaller and smaller craniotomies. And actually, he convinced me that there is less morbidity with them, and there is less morbidity, less pain, less infection, and actually less risk of damaging the veins. Obviously, you have a smaller field. So in my opinion, you should have done a lot of more open approaches to be familiar with the venous anatomy and then go to more minimal invasive ones.
Tina, do you do a sitting position for pineal?
You cannot find an anesthetist to do that. No.
Sorry?
No, our anesthetist won't agree with that.
I totally agree with the anesthetists because I don't like the working like up in the air.
Yes.
I totally agree with you.
Okay, so I'd like to wrap this up now. I think it was great talks. It was a great discussion. I thank you all for your amazing talks and your time, and I hope that all the audience took some very valuable information with them. And I thank the panelists for keeping up the discussion, and I wish you all a nice evening.
Thank you.
Thank you very much.
Thanks a lot.
Thank you.
Thank you. Ciao.
Bye-bye to everybody.
Bye-bye.
Bye. Thank you.
Bye bye.